Hi, good evening and welcome to this evening's Trauma Care webinar. My name is Andrew Umrod and I'll be facilitating tonight's webinar, and I'll very shortly be handing you over to Dr. Deborah talking triaging the trauma patient for infection. If you've never been on a webinar before, there's a little webinar disclaimer that any learning that has taken place during this webinar should not solely be relied upon. You probably saw a massive disclaimer at the very beginning when you logged onto this webinar, and that's just a very long-winded learning disclaimer that you're more than welcome to read through. It's a bit like when you download an Apple update and you scroll through to the very end and just click accept. So that's ultimately what you've done by joining us tonight. I can already see some participants coming online. Please use the chat function if you want to interact with each other or share any really useful learning tips, or you can use the Q&A option and we'll line the questions and answers up for Dr. Deborah at the end of tonight's presentation. We can't see or hear you, as it says on screen, so you don't need to panic around unlocking or locking your microphones. They'll all be locked and we can't dial in and see you at all. If you are a member of Trauma Care, you will get a CPD certificate that will come tomorrow. Lauren normally sends that out around 10 o'clock in the morning, and that will come to your email address. And you'll also all get a copy of the edited recording, which will again come out within 24 hours. So it normally comes out exactly 24 hours. So 8 o'clock tomorrow night, you'll normally get that in your email box. There will be some opportunities tonight to scan QR codes on screen. So if you have got that capability, then do that and you'll be able to scan some of our upcoming webinars. And if you are on social media, please do follow us at Twitter at Trauma Care UK. And if you are going to share your learning journey with us tonight, please use hashtag TraumaCare2021. It's always good to see what you're up to tonight and how you're taking part in this learning, whether you're sat on the settee in your pajamas or whether you're indeed at work in your department or maybe out mobile in your car. But obviously make sure that you don't take a selfie if you are driving, because that would be dangerous and we don't want to take trauma to another level. If you haven't done so already, please do not miss on this two-day amazing event. I am so excited because I'm going to this event on the Saturday and Sunday, and it is almost sold out. I think we've got about 25, 30 tickets left. It's a two-day Foundations in Trauma course on Saturday the 13th of November and Sunday the 14th of November. And most exciting, it is a face-to-face event. Yes. That means we'll be mingling with each other safely, of course, but there will be a face-to-face event. So it's down at Yarnfield Park. It's a two-day learning event, and it's only £120 for the 2 days, and it's CPD certified, and you'll get appropriate points. And this course has been pretty much run for a few years now. Every time I go there as an experienced practitioner, I pick up some new tips and tricks and the latest evidence and research. So it's welcomed and open for either newly qualified professionals, students in the healthcare setting, but also people who've got a few years under the belt like me. I know I don't look old enough to say that, but actually I've been around the block a little bit. So if you're looking to refresh or brush up on some of those trauma skills, then do not miss this great opportunity. And again, you'll work as allied professional teams with radiographers, paramedics, nurses, doctors, and you'll work collaboratively. And what I will tell you is that the course is set up so that you have a very small amount of theory, presentation, and then it is literally practical. You literally will be hands-on managing patients. So please scan that QR code, or you can go to the Trauma Care website and you can take part and book a ticket. And I think the accommodation is exceptionally cheap as well and includes dinner, bed and breakfast. What more do you want for a weekend in November? If you're not a member of Trauma Care, please consider becoming one. We have got two great rates, one for students, one for full members. And full members, of course, get a copy of our printed journal, which comes out to you from our partners at Sage. So there is lots of great benefits there, including the ability to get a CPD certificate every time you attend one of these live webinars. And if you're not a member, you can either join tonight and get a certificate, or you can pay for certificates and 100% of that money goes to the charity. And I'll pop that link in the chat at the very end. It's always good for you guys and girls out there to share our learning, because these webinars are completely free to attend, supported by our key sponsors, which we'll talk about at the end. So please do scan that QR code or download our Trauma Care poster and pop that up at work, whether you pop it in the mess room, whether you pop it on your learning and development board. I've seen them on the back of toilet doors before. Not sure I advocate that practice, but I have seen it. Not sure what you do when you're sat on the toilet, but popping on a poster and pulling your phone out your pocket, maybe, who knows? Maybe I'm just old-fashioned, I don't know. But please do download that poster and share it with your colleagues and your learning and development teams. That leaves me to say thank you very much, Dr. Deborah. Are you there?
I am. Thank you, Andrew.
I'm going to hand over to you now. Thank you very much.
Okay, thank you. And hello, everyone. Thank you very much for joining us this evening. Now, let me just share my screen. Bear with me a sec. Okay. So, thank you for joining us. I'm going to be talking about infection in the trauma patient, and it's kind of my perspective as a mere microbiologist on perhaps a different angle on triaging the trauma patient. And I'm aware that many of them have a long survival journey, and it's a long and extraordinarily difficult journey against the odds. And the fact that most of them, many of them, make it against the odds is testament to all the fantastic work you guys do. So it's a real pleasure to be talking to you today. I'm aware that you've got lots of tools and snappy acronyms and all the rest of it. So I've decided I'll take a liberty as a microbiologist and invent one of my own. So what I'm going to do tonight is, offer you what may be hopefully a survival tool for you to chart through the uncertain wilderness of infection in a trauma patient, with a view to playing a small part in improving outcomes. I thought, if you'll forgive me, I'll use a metaphor of a journey. Most of us haven't been away anywhere for a wee while. So I'm going to take you through that wilderness of uncertainty. And I'm going to invite you to come on a major trauma service infection safari with me and have a look and see what we might find. One other aspect of this journey is there may be a bit of turbulence. You might have detected the fact I'm a bit croaky. I've got a dreadful virus on board. So I've already explained to Andrew, if I have a paroxysmal coughing fit, I've already had one in the last half hour, I'm just going to put my microphone on mute and maybe have to leave Andrew to entertain me with some jokes for a bit until I'm able to come back. So I apologise in advance if that happens, but I'll see if I can keep it under control. So if we're ready to go on the journey, we shall begin. So many, many years ago, when my boys were small, I read them stories from Arthur Ransom's Swallows and Amazons. And when the kids went off on their imaginary journeys into these far-flung places, they took some pemmican with them, which always sort of intrigued me, the concept of what it was. It's actually a survival tool. It's made of dried meat and seeds and high protein stuff, and it comes in all shapes and sizes like our patients do. And if we think about the safari we might be going on, the one on the top left looks like it might well have come off the back end of something we might find. But there we go. Bear with me. This does have some relevance to what I'm going to be talking about. So moving on, I came up with this idea of Pemmican Plus. You guys have your AppMist and you've got lots of other snappy acronyms. So, I thought, why can't I have one? And then when I sort of developed this, I thought, oh dear me, this does look rather like a snappy name of a new antibiotic. Well, clearly antibiotics do have their role in trauma patients. I don't need to tell you that. But hopefully this will be a framework that will enable you to think about how you approach a trauma patient with a view to using your antibiotics judiciously. They clearly have their place, as I say, but they've got some downsides, as you well know, and we need to use them judiciously. And my approach to thinking about assessing trauma patients has also been informed by some of the experience I've had with working with my military colleagues and thinking about the military colleagues, casualties, as well as our civilian trauma. So let me explain to you what Pemmican Plus is. The whole idea of this is actually considering the whole story. I am painfully aware that when the paramedics, the pre-hospital team hand over to ED, you've got a few things you need to hand over really quickly. So a lot of what I'm now going to talk about is absolutely not the stuff that you're going to be talking about in that context. You know, this is not AppMist with a few bits added on. This is a kind of slightly separate compartment, if you like. But there are elements of this that will be captured by the pre-hospital team, and it's really important not to lose that. So could I ask those of you who work pre-hospitally to just kind of consider other bits of information that you might have that need to be incorporated into your notes that everybody else can access later. So you can see, as we look down that list, that's where I got the abbreviation of PEMICAM from, and the plus because I couldn't think of anywhere else to fit that bit in. So I'm going to take you through each bit individually and think about, from my perspective, when I'm sitting in the MDT or asked about a patient, the sorts of things that I, as an infection practitioner, are thinking about that helps me to decide whether this is infection or something else. And if it is infection, what I might need to do about it. So we'll start with patient. And this moves beyond age because there's lots of other things about a patient that are important in terms of thinking about infection. The first of which is predisposition to infection. So what is it about the pre-morbid state that we need to know about their past medical history? Well, things like diabetes, immunosuppression, any steroid therapy, or other diseases, things like lupus that might predispose to immunosuppression. Or have they actually got a coexistent infection? The reason they got run over by the bus is because actually they've got a dose of community-acquired pneumonia. They're feeling lousy, they're not on their toes, they weren't concentrating, and that's why they got almost squashed by the bus. And the reason for emphasising that point is that being aware of those broader horizons may influence our choice of antibiotics in the early phase. They're not going to influence your first-line antibiotics that you would use in the context of trauma, if indicated, but it may mean that very early on in their course that we want to add something else in to treat, for example, community-acquired pneumonia. So we shouldn't miss that. And there's other things about the patient. You know, pregnant patients are prone to a different range of infections altogether. And also some things about where's the patient been. Travel-related infection and a travel history is important. So you can see there's a lot of stuff in there that moves you beyond the A in AppMist, moving on beyond age. There's a whole bit of the person that would be helpful to capture. Moving on then to environment of injury. There's a world of difference in terms of the microbiology of the farmyard versus the front room. There's things that live in brackish surface water, such as Aeromonas, that can cause infection. And the importance of some of this stuff is that those organisms may well be resistant to our first-line antibiotics. We have patients who fall into canals, and we've seen chest infections with some slightly unusual environmental gram-negatives that lurk in that sort of environment. Or we get inoculation of organic matter that can very rarely cause fungal infection. And that really takes me back to the experience with some of our military patients. So I think the environment of injury is somewhere where our pre-hospital colleagues can really give us some very rich information. And I'm aware that we sometimes get photographs of the scene of the accident. So, a picture tells 1,000 words, but at least capturing a description of where the patient fell. I can think of a patient relatively recently that we had who had a nasty open tibial fracture and he just didn't settle down. We knew he lived in a rural area, and he was said to have fallen off a gate, and that sort of intrigued me. That fell off in a gate into what? Into a cowpat? Onto some concrete? Where was it? So that was quite difficult to get that information. So just capturing those simple things can really help us down the line when we're thinking about things that, particularly if things aren't going very well. So things about the environment of injury make me as a microbiologist think about the range of pathogens I might need to worry about, and the choice of antimicrobials that might be driven by that, with my understanding of mechanisms of resistance and all the rest of it. don't expect you guys to know about that. I don't want to do myself out of a job, so that's fine. You don't need to know the list of organisms, but it's just that basic information that helps the team decision. Thinking then about mechanism of injury. That's probably far more straightforward and accessible for us all to understand. If you fractured your ribs when you've got a contusion, then you're going to be at risk of a chest infection. But mechanism also involves inoculation of stuff. Well, a penetrating injury, but with what? Where's the thing that penetrated? Where's that beam? What was it? Is there anything intriguing there about the range of organisms one might encounter? And that kind of moves neatly into the actual injuries sustained. And from my perspective, it's you would think about the need for damage control surgery. I would think about the need for damage control antibiotics that go beyond our usual co-amoxiclav. So maybe some injuries might predispose to yeast infections. Perforation of some viscus might be of relevance there. So I need to understand the injury, and there's also things about the evolving injury or things that we might have missed. So a bowel injury that wasn't apparent on the initial CT scan, there might have not been a perforation at that stage, but the natural history of that is that it will evolve and perforate sometime down the line. So thinking about that mechanistically is really very helpful. And that's taken me quite a number of years to sort of get my head around that and what I need to worry about. And then, of course, there's lots of things we do to patients. There's interventions, diagnostic, therapeutic, and supportive. So some of the diagnostic interventions that we might make, things like the finger thoracostomy, for example. You poke a hole through skin, there's bound to be a small risk of infection, however carefully you do it. So every time we breach a normal anatomical barrier, and a lot of the time that's going to be the skin, we run the risk of infection. And we take lots of opportunities in managing the trauma patients, particularly the polytrauma patients, to stick lots of bits of plastic in to save their lives. Interventions also mean surgical interventions. Again, a breach of anatomy, things like Reboa. And what about thinking, perhaps merging with the next heading of complications? How long did that stay in? Is there any risk that the gut could have been compromised, for example? So, what are the interventions we've done? And then thinking about the complications of those interventions and the complications of surgery, from skin and soft tissue infection, or for breakdown of anastomoses and the inevitable sort of tension, shall I say, between teams of those who think there might have been a breakdown and those who conducted the surgery saying, no, it can't possibly happen. And the sorts of complications we need to have about that kind of stuff in a multidisciplinary team environment to make sure we're not missing anything. And then there's the supportive interventions that we make. So many of our patients will go to ITU. We'll stick lines in, they've got intercostal drains, they've got intracerebral pressure, intracranial pressure monitors, they have lumbar drains. It never ceases to amaze me what the intensivists and others find to stick in people to support their journey. We move then on to A, the acquired predisposition to infection. That's quite a tricky one, really. We do know that trauma itself and the physiological insult will lead to relative immunosuppression, but so too will things like blood transfusion. Quite subtle, but we just need to think about that as upping the risk of infection, and things like steroid usage for ARDS a little way down the line can cause problems. We absolutely shouldn't forget about nosocomial infection. We seem to take quite a lot of opportunities in day-to-day care to share patients' flora around the place. And particularly if we've got patients who've had healthcare elsewhere, It may be that what's going around another hospital in the UK, if we're thinking about repatriating our patients internally within the UK, each hospital does tend to have its pet flora, and we unwittingly share it around the country. But perhaps even more challenging is those who've had healthcare abroad, where their systems of infection control may not be as developed as ours, and God knows we get it wrong often enough. And so we really need to be mindful about thinking about what's knocking around elsewhere, but also what the sensitivity patterns are if we need empirical therapy of infection. And then the plus, as the final point on this, I've labelled it the infections we can't see. Perhaps they're not the infections we particularly think about acquiring in the context of trauma, and I'm thinking there about things like the bloodborne viruses. There is data out there to say patients who present with trauma are at higher risk. There are patients who've got HIV, and that may actually be coincidental, but there's an opportunity for us, because we've got the patients under our care, to adopt a holistic approach about thinking of what they might be vulnerable to and doing some very simple screening. And certainly if patients have had healthcare abroad, particularly in the developing world, the risk of bloodborne virus infection from therapeutic interventions cannot be underestimated. And what if I've had a blood transfusion abroad? I'm sure there's many places where they don't have the luxury of the level of safety we have with our own UK blood supply, or European blood supply for that matter. So there's a lot there, and as I say, I'm absolutely not suggesting this is the sort of thing you're going to be chatting about during the trauma call down in ED, but they are things that we need to be thinking about, and things that we need to be capturing the information, and when we have the opportunities, perhaps when talking to the next of kin, just to find out more about the patients. Who are they? Where have they been? What about their past medical history? And making sure we're accurately capturing that data. So that's my Pemmican Plus survival tool, survival kit, if you like. And I hope that gives you some sort of a map to thinking about the kind of stuff that I, as an infection practitioner, would be thinking about needing to know. The next thing we need to be very, very clear about is that inflammation and infection may present with the same physiology, and to some extent, they may present with the same blood markers. And here it's really important to be thinking about the timeline when you're interpreting these lab results. And when I'm talking about lab results in this context, I'm thinking about CRP and white count. And I'll come back in more detail to that right at the end when I walk you through what admittedly is a rather busy slide, but it's about the timeline of infection versus inflammation. So trauma itself is a huge physiological insult. It's inflammatory. The white cell count will go up. The CRP will go up. So it is of no earthly use whatsoever in dissecting infection from trauma in the first few hours, days. And it was quite interesting at the MDT just a couple of days ago. There was an entry from a medical team who sometimes help us with our trauma patients saying, blood suggests infection. Well, you think, actually, this is somebody who's had a catastrophic injury. They're within 24 hours of admission. No, it doesn't. This is the normal response to infection. So I think we need to be mindful that people who maybe don't have quite so much contact with trauma services who we might ask for advice might be unaware that actually a white count of 25 in a trauma patient in the first 24 hours is actually perfectly normal. I would probably worry if they didn't have a high white count. So just bear in mind how we interpret these things that we often use as shorthand for infection. So here I'm going to invite you to come on the Major Trauma Service Infection Safari. We'll have a look at the big 5 and see what we can find. So I've called this What We See, but actually I think it's fair to say it ought to be entitled What We Treat. And it is my anecdotal impression, but in defence, having passed it by some of my trauma colleagues, they didn't disagree with my view. And the reason I say it's what we treat is because, for the most part, our diagnostic tools for infection and diagnosing it with certainty, particularly in a complex polytrauma patient, our diagnostic tools are fairly lousy. And it comes down to interpretation, both of the laboratory results, but primarily it's the end of the bed, the common sense, what's going on here, what are the possibilities, and thinking back to the pemmican idea, and then thinking forward to where we are in the timeline, which I'll come on to, is what are the possibilities? So I think pneumonia's got to be up there. A lot of our patients have chest trauma, which clearly does predispose. A lot of them have other trauma that immobilise them. They're in pain. They don't move around. They don't cough. So it's not surprising that pneumonia is perhaps top of the list. I suspect it might not be quite as common as we think, and that some of the antibiotics that we're using for so-called pneumonia are probably not quite justified, but hey ho, we have to live with that, and we have to be pragmatic about our decision making. Skin and soft tissue infection will always be in there. We've made holes in people. They've had traumatic holes made in them. We've made therapeutic holes, some of which are surgical, others are through other interventions. I have to say, though, I don't think we see very much skin and soft tissue infection. And given the circumstances of trauma in the community, that's perhaps surprising. Or maybe it's just testament to the fact that the guys pre-hospital are really very, very good at getting the antibiotics in there early. And the story about keep it simple, because certainly in my neck of the woods, you know, it's coamoxiclav, it's there to get the staphs and the streps, a few other bits and bobs. Keeping it simple seems to serve us very well. I think getting them in early, and there's plenty of clear guidance out there from NICE and BOAST and all the rest of BOA rather, are out there. So I don't think we see a lot of skin and soft tissue infection. But of course, it can be problematic and can cause a great deal of morbidity when it's a surgical site over some nice new shiny orthopedic metalwork, and all the consequences of that down the line. So it's important we're on our toes and looking out for it. Urinary tract infections in there. I think there's a lot of overdiagnosis of that. It does tend to be a bit of a dustbin diagnosis. Urine dipstick testing, particularly in the older patient, is completely without utility. They will have a positive dip, and that does not represent a diagnosis of a urinary tract infection. Somebody with dysuria and a laboratory urine that substantiates that is fine. I'll live with that as a diagnosis of UTI. So I suspect there might be a bit of overdiagnosis there. And then neurosurgical infection, and I put a query there because I see a lot of patients on ITU, the polytrauma patients who may have had a decompressive craniotomy, they may have had a base of skull fracture, they may have had a bolt in or an EVD in. They've got a fever. There's no other particularly obvious cause, but as I've said, I think our diagnostic tools for really nailing a source of infection are relatively poor. And because of the nature of their injury, getting a CSF sample is not going to be safe, and it ain't going to happen. So I think there's quite a lot of patients we cover empirically for neurosurgical infection because it's the safest thing to do. There are no prizes for missing meningitis and under treating it, let's face it. And I think we just live with the fact that we empirically treat a number. We will never get to the bottom of whether they really had neurosurgical infection or not, by which I really mean meningitis. And we just do the 2-week course and have done. And then orthopedic infection. I've put in there, there's clearly some acutely. I've mentioned the skin and soft tissue infection over the new metalwork, and some of that has to be unravelled fairly quickly, although that doesn't happen all that commonly, in all honesty. And there will always be a tail end that presents down the line of orthopedic infection, either associated with metalwork or with an infected non-union. But actually, again, thinking about what happens to patients, it's quite surprising in a way how little of that we see. And I think because of the nature of where I work, I think I would see the tail end of that. So So there we go. Those are my big five. And it'll be interesting to see whether that echoes other people's experience. But I say when I bounce this off some of my orthopedic colleagues, they didn't disagree. And they do often feel brave enough to disagree with me. So I think that's a positive point. So I think that needs triangulation, because actually we don't have any very good data. And there's some data out in the literature, but I think it's always very hard when you're trying to compare institutions in different healthcare systems. It's not always clear what their pre-hospital antibiotic practice is like, and so much else. It's quite difficult. So I've said there's no good data because what I really mean is I have no good data from my own institution. I did look at the TARN database for those of you thinking, well, there's bound to be something in there. But actually the TARN data that we've collected locally is not fit for purpose, and it was so poor that we've actually decided to stop submitting it. So that's a bit of a disappointment, and maybe something that might be addressed in due course. But that's a tangent. So I mentioned that part of getting to know our patient is thinking about where they've been, and this idea that they may have been somewhere. Well, okay, I appreciate that's not perhaps quite so likely over the last 18 months for obvious reasons, but there is the possibility, particularly when we get back to going into more exotic places, that we will acquire what I've put in inverted commas as foreign infectious diseases. As a rule of thumb, the things that we might think about exotic infectious diseases that you get from abroad, things that we might have learnt about as medical school or wherever else, and we've long since forgotten about, actually most of that stuff will present within about your first 3 weeks back in the UK. So if your patient's outside of that time frame, it's reasonably unlikely that they've got something, excuse me, something frightfully exciting and exotic. There are some caveats though. As I've already mentioned, healthcare abroad, and particularly transfusion abroad. So conversion for hepatitis C, hepatitis B may take longer than that. It may take longer for HIV to become apparent, or it may actually not be apparent. You may not get any sort of seroconversion illness and it will be silent. So we are actually on about to think about that sort of thing on behalf of our patients, because there are some public health benefits as well as individual benefits for cracking that stuff. But if we're thinking back about to exotic stuff, don't forget about malaria. Whilst malaria may present acutely, it may not, and you can get relapses of malaria certainly up to a year after leaving a malaria area. So that very much goes back to the patient, who they are and where they've been. And 12 months is a reasonable rule of thumb, but can be later. There are some patients with Vivax who will get relapses for longer. So a fever may have nothing to do with your trauma or putative infection related to that. It may represent something that's pre-existed for a long time. And never forget about TB. Likewise, that can come back to bite you later. As a story to bring that to life, many, many years ago when I was a wee registrar training the other side of the city, we had a lady who was Pakistani by background who'd been found on her garage floor with a knife in her belly. We patched her up on ITU. She was still on ITU. Chest was awful. She really wasn't doing very well. And I remember saying to my boss, "Oh, do you think we ought to think about malaria?" Thinking, oh, that's a bit smart-ass one. No, she didn't have malaria. A couple of days later, we were still agonising about what was going on. She was pyrexial, they were having trouble with their chest and all the rest of it. And we looked at her chest x-ray, and I remember saying to my boss, "You know what? If I said to you, I've got a Pakistani lady with that chest x-ray anywhere else in the hospital, what would you think the diagnosis might be?" And we both looked at each other and thought, oh God. She was actually smear positive. You know, she had galloping consumption big time, and there was quite a bit of trouble in unravelling that from the infection control point of view. And that is a lesson that has stayed with me for decades. So patients who present with trauma do have other stuff going on, or they have really bad trauma and they can reactivate latent infection. So as another example, what about your patient who's, I don't know, 94, who's had trauma and is creaking back? Well, it's 76 years post-Victory Japan Day, and it's not unheard of that patients given a dollop of steroids after that reactivate their strongyloides and they can become really, really sick. Okay, I know that's really small print stuff, but it's just as an example of thinking more broadly about where our patients have been and what they might have on board, that unless we pay attention to that sort of thing, we will completely miss. I'll say I've been caught out before in my youth. So this is my final slide, and I'm going to take a few minutes to go through this. I apologise for the fact it's very, very busy, but bear with me, I'll walk you through it. So the first bit I'd like you to look at is this yellow stripe across the middle. And I said right at the beginning that we need to think about the kind of, if you like, the pemmican approach of all the things we need to know about the patients, but we also need to think about the timeline of where they are in their journey. And for me, it breaks into a sort of 4 discrete areas, but there's no distinct cut-off between moving from one phase to the other. So first few days is a bit elastic. I guess conceptually I'm thinking 3 or 4 days, but might be sooner. And right over on the left, you'll see I've put fever, raised CRP, white count, or raised inspired oxygen, thinking particularly about the ITU patient and the polytrauma patient. And in fairness, most of what's contained in here is directed towards thinking about our most complex polytrauma patients who are going to be in ITU. So in the first few days, as I've already touched on, I think the CRP and white cell count are completely meaningless to point us in the direction of infection, to the point of just ignore them. And up at the top, above, oh, I've lost my mouse, there it is. Above the yellow band is the things I've categorised as infection. I have to apologise because I can't quite see the top of my slide because I've got a stripe of Zoom controls, which I don't move in case I do something catastrophic. But there's the list of things that I've really talked you through in the first slide. So things about wounds, things about devices, the interventions we've done. So when I'm on ITU, metaphorically stood at the end of the bed looking at the patient, I've got this kind of top to toe approach about what's where, what bits are plastic, what have we done, where are the surgical wounds, where are the trauma wounds? Because, you know, if somebody's been in there, it makes common sense to think that might just be the source of the mischief. And I'm also mindful about things like visceral perforation now presenting that was legitimately missed at presentation because the signs weren't there, or an evolving injury. And we've already talked about the natural history of a perforated bowel after trauma. So those are sort of the infection type stuff I think about. But very early on, there's a lot of non-infective stuff, which is the inflammatory response. So there's a SIRS, the ARDS, perhaps a bit early for ARDS. There's foreign bodies that might still be in there, which might be a nidus of infection. You know, it might actually be a lump of infected material that's been implanted. You can't allow, or just inflammatory. Sputum plugging, well, that's going to put your FiO2 up. A pulmonary contusion, you know, bruised lung ain't going to exchange oxygen as well. Transfusion-related acute lung injury will compromise your respiratory function, and then pulmonary embolism and fat embolism. If you've been blown up, you might have blast lung, or you might have a large effusion that's compromising lung expansion. An intracerebral bleed will be inflammatory. Blood in the wrong place is hugely inflammatory. Urine in the wrong place is hugely inflammatory. Bile in the wrong place, hugely inflammatory. And actually, just as a story to bring that to life, we had a young lass who we were a bit slow, in all honesty, in spotting the fact that she had a urethral injury and she was leaking urine into her peritoneum. She managed to get her CRP up to mid 600s. I don't think I've ever seen a CRP that high. we were slightly sort of misled, thinking this might be infective, but actually I think it was probably just inflammatory. So there's lots of very different non-infective causes in those first few days that we need to be thinking about. And that's the sort of conversation I'll have with my intensive care colleagues, really just testing out, do we really need to escalate antibiotics? Maybe even a conversation about, are we brave enough to stop them or not start them? I appreciate it's really difficult, and sometimes we just have to take the view that the risks of compromising a patient by not treating possible infection will hold them back, and we just do it. So I'm not pretending we adopt a purist approach. We have to be pragmatic at the end of the day. The next section down, with the sloping title of Housekeeping Checklist, is a sort of note to self and others about the things we just need to check out. You know, what is the past medical history? Have we got a clear view about really what happened to them? And that takes us back to the PENICAM acronym. Did we replace the trauma lines? Although I think the guys pre-hospitally do a fantastic job of putting them in pretty cleanly, I recognise they're doing some of their stuff under extraordinarily difficult circumstances. So have we replaced them? Is what's in there, hand on heart, really put in with proper sterile technique? Did we actually give prophylactic antibiotics? Some things about, as again, a checklist. Did we give pneumovax? Have they had their tetanus vaccination? And have we done a bloodborne virus risk assessment? So some of those things are kind of my housekeeping checklist. They won't be masquerade, they won't be presented as infection there, but they're my note to self, things I need to ask my intensive care colleagues about. But I think it's fair to say in these first few days, infection's rather less likely. Most of what we're likely to be seeing is the inflammatory response to trauma. So I'm going to move you now on to the second column, which is the first week. Well, all of what happens in the first few days can still be pertaining in the first week. And again, this first week is a little bit elastic as whether it's the first 7 days or the first 10 days. But here we might be needing to think a little bit more about infection becoming the cause of a raised CRP or white count, particularly if we've seen the peak in the first couple of days has settled or has gone down and is now tracking back up. That, to me, you cannot reasonably write off as a response to trauma, because why did it go away for a bit and then come back? That doesn't make any sense. So when I see it rising, I'm thinking, yeah, okay, I'm happy now to think that that's a marker of infection. And I'm starting to think about the complications of treatment, so the anastomotic breakdowns, perhaps neurosurgical infection after a craniectomy or a base of skull fracture, and something's crawled in. But we've still got all this non-infective stuff below the yellow line, much the same as in the early days. But we might now start to be thinking about things like pancreatitis or acalculous cholecystitis, and I apologise for the spelling mistake there. You know, a Scotch pancreas that's not infected, but actually it's jolly unhappy and clearly hugely inflammatory and a very sick patient sometimes. And coming down to the housekeeping checklist, have all the devices been removed and reviewed? And actually, have we remembered to take out what we're not using? There's no point leaving a central line in for longer than we need and all the rest of it. And it behoves us to reevaluate stuff, including going back to the beginning, reevaluating the history, reevaluating that imaging and thinking about, is there something that we could have overlooked at the time in the heat of the moment? And let's face it, even with review, we have all our CT scans reviewed by a radiologist, but human factors involved, you know, nobody's going to pick up 100% of pathology. So we just need to respectfully challenge some of our reporting, some of our own views about what went on at the beginning, and reevaluate what's going on. But as I say, I think in this first week, when we're seeing raised inflammatory markers, it is much more likely to be thinking about infection. And then we move on in our patient's journey to the third time frame, which I've arbitrarily called sort of 2 to 3 weeks on a fairly elastic basis. And it's the tail end of what we're seeing in the first week, but we're starting to think now of the possibility perhaps of abscesses or intracavity collections. So liver lacerations, renal lacerations, presenting with an abscess. I have to say, it's extraordinarily uncommon. It's described in the literature, but even though we are actually, as a unit, I think quite circumspect now about giving prophylactic antibiotics for that sort of thing, I don't think there's a trail of devastation with organ-based abscesses. And I think we would know, because of the nature of our service, it will come back to the same hospital. We would know if there's a trail of devastation there. So I think for me, that underlines the fact that it is possible to be sensible and judicious about our antimicrobial usage and not have a devastating trail of infection along the lines. We need to think about surgical site infection, skin and soft tissue. You know, it's the top to toe, examine the patient properly, see what's cooking. And if there's nothing clinically obvious on examination, then our recourse to imaging. And we shouldn't forget about the possibility of a PE. You know, have we actually forgotten to restart the enoxaparin after we suspended it because they're going to theatre? Or maybe we're a little nervous about using it at all because of our concerns about neurosurgical hemorrhage. So never forget about PE, and that extends throughout the hospital stay. Again, things like pancreatitis and cholecystitis, which are admittedly very, very uncommon. Back to the housekeeping then. Get the plastic out, review it, and if it's not needed, get it out. And in the notes section right at the bottom, we're thinking now if we have got infection, by definition, it's quite likely to be nosocomial infection and might therefore have a more resistant flora. And that might just influence our empiric choice of antibiotics. And that's where perhaps a more specialist and nuanced discussion about what we're going to use is very helpful as part of our MDT work. And then finally moving to the rehab phase, which for many of our patients is a considerably long phase, starting, hopefully, the rehab starts within the first few weeks, but of course some of them will still be having a sort of interventions to manage their direct trauma. So in the rehab phase, we're sort of getting on to think about things like implant-related infection. You know, has the metalwork come a little bit unstuck? Are other devices now infected? As I said, we're moving below the yellow bar now into non-infective causes. Don't forget about PE, but things like big hematomas, lysing can be quite inflammatory, but also other things like heterotopic ossification will see a raised outfos, but it can present with a temperature as well. Well, I think back to a patient who I remember having conversation that we thought he probably had biliary tract infection because he had a high outfos and a temperature, but the imaging was normal. And it wasn't until some weeks after I thought, actually, I didn't think at the time, was this just HO? Because I don't often think about it being associated with a temperature, but it very clearly can be. So I think we rather missed the point there. I don't think he came to any great harm, but it did mean he had a week's worth of tazocin empirically, which was probably not indicated. Then there's some other things like Dressler's syndrome, which is an inflammatory response you get in the pericardial tissue after cardiac trauma. Many of you might have come across it more commonly discussed in the context of myocardial infarction, but it clearly occurs after cardiac surgery or cardiac contusion. So that will present with a fever, with pain, and with raised inflammatory markers, and a pericardial effusion. And we certainly grappled with a patient I can recall as a trauma patient, and everybody was mystified as to why he'd still got this effusion and what was going on there, and was this infection? Well, actually, no, it wasn't. It was Dressler's and a bit of non-steroidal, all melted away. And then again, we still come back to the housekeeping. Have we got rid of all the devices? You know, is it really time to get the urinary catheter out? And again, there's a big piece there about rehab, about normalizing a patient. You know, our normal state of existence isn't with lots of devices hanging out of us. And I think we're sometimes a bit naughty about not remembering to remove them early enough. And of course, we're still in this rehab phase, patients still in a healthcare environment. So if we do get infection, there's a higher risk that it's going to be more resistant. And again, we'll alter our empiric choice of antibiotics. So that's where I'm going to end. And very happy to take any questions and discuss further. But I hope you've taken away from that a sense of there's a bit more that we can usefully know about the patient when we're thinking about infection. And then if we are thinking about infection, it's really very helpful to think about where the patient is on their journey of care. So as I say, I'm very happy to take any questions and continue the conversation. So Andrew, back to you.
So Deborah, thank you very much indeed. Certainly an engaging presentation. Thank you. And you managed to get through without your coughing fit. I was lining jokes up, thinking these aren't going to be funny. These are not going to be funny jokes, but we managed to get through it. Let me share my screen. But fabulous. There we go. So I'm going to give people a couple of minutes just to pop some Q&As in the, because we've got 3 questions lined up for you. Well, one of them is a comment from our very own Professor Sir Keith Porter, who's put excellent presentation and overview. Many thanks. I told you, he may be on tonight.
Thank you very much, Keith. As I said to you, Andrew, he's being nice to me because he wants me to organise something for trauma. So, but thank you all the same, Keith. I'll take that as it is.
Fabulous. I'm going to give people a few minutes to just pop some questions in there if you have any questions for tonight. We've got a few people from around the country tonight. We've got Brian from South Cheshire. We've got Paul, who's a nurse from Essex. Daniel, who's a CFR from not so sunny Blackpool. Yes, it's wet and windy here, Daniel. We're not far away from you and it's miserable. David, who's a paramedic from Staffordshire. Julia, paramedic from Central Scotland. I don't know what the weather's like up there, Julia, but it's miserable here in the middle. Jane, who's a critical care outreach from Chris, paramedic from Bedshire. Michael, clinical training manager and assessor. Lots of fab people on tonight. Thank you so much indeed for joining us. I did ask the question in the chat, is anyone using prophylactic antibiotics or antibiotics pre-hospital? And a few people have come back there, Ian, Julia and Michael. So please do share your uses and whether you use antibiotics in the chat. That'll be useful for us. Our trauma care shop is live and open. I normally have an hoodie on tonight, but I haven't because I've got a really warm jumper. But if you want one of our trauma care hoodies, available in blue, black and green, they're available now in our shop, as well as also our trauma care manual, pre-hospital manual, and you just need to scan that QR code, or you can jump over to the trauma care website. We have some more great webinars coming up shortly. Critical Decision Making in Extrication by our very own Tim Nutbean, and that's on the 3rd of November. And then we've also got on the 1st of December, Heading and Head Trauma in the Premier League, Making the Right Call by Dr. Mark Gillett. So please scan that QR code. And there is some more webinars being jiggled around a little bit. So please jump over onto the traumacare.org.uk webinar and you can have a look at what's coming soon. All these webinars are fascinatingly brought to us, fully supported by our sponsors. So we've got Galen, who are the maker of Penthrox. So please do scan that QR code or go over to penthrox.co.uk where you can capture more. Gosh, it's catching. We're not even in the same room. Well, there's some more information there. We have got our other sponsor, who is Safeguard Medical, part of the sponsor of Watergel Technologies, and you can go over to watergel.com and find more information. And our third sponsor from this evening, fully supported, is Icarus, who are currently recruiting. So please go across to icarus.com or have a look at their website. And if you are at the Foundations in Trauma course, our sponsors will be down there showcasing some of their amazing products. So please jump onto the Trauma Care website and get yourself a ticket for the Foundation in Trauma course. Somebody asked in the chat, how do I get a certificate? Well, if you're not a member of the Trauma Care, then you can scan that QR code now and you can get a certificate tonight. Chris has asked, when I was in the army, we gave MagnaPen IM to all trauma patients in the field. UK paramedics only give IV IM antibiotics pre-hospital for meningitis. I think there's a few more reasons now they give them, Chris, as in the chat. But do you believe we should be treating trauma with antibiotics like the army do?
I think that's very clearly, oh, excuse me, very clearly a place for prompt antibiotics in open fractures. So it depends what you mean by trauma. But I think if you think you've got an open fracture, absolutely, it's in NICE guidelines. You need to crack it in within the first hour if you can. In terms of agents, I think keep it simple. Certainly the UK military do that in their battlefield injuries. The American military go completely over the top and use carbapenems. I don't think that's at all justifiable. But there we go, difference the other side of the pond. Ceftriaxone, yes, if you think you've got somebody with meningococcal sepsis, absolutely. But I don't believe that's got any place in trauma. It will, in fairness, cover most of the pathogens that you need to, but it's inappropriately broad spectrum in my view. So what we do locally is we use coamoxiclav, and for penicillin allergic patients, we use clindamycin. Will that cover all known germs? No, of course it won't, but we have to be pragmatic. And I think the mainstay of managing infection is, you know, that first bit, prompt antibiotics, but it is prompt surgical management of the wounds, whether that's just a washout or whether it's something more definitive. But prompt surgical intervention and debridement is undoubtedly important. And I think that's why we see so little skin and soft tissue infection down the line. But as I say, I wouldn't pretend coamoxiclav's going to treat everything. But if we wanted antibiotics that will treat everything, it will be a complete overuse and abuse, and we get the side effects from that. So I hope that addresses your question.
Perfect. Thank you. We've just got two more very short questions. Brian is asking, what about the role of antivirals?
Well, in the acutely injured patient, none. I think if you're thinking about the bloodborne viruses, hepatitis C, absolutely, it is now a curable disease, which is why there's a prize for making that diagnosis. Hepatitis B, there's a role for antivirals too. If you're thinking about post-exposure prophylaxis for HIV, I think that's going to depend very much on the circumstances of the injury. And if I think more broadly about the the national guidance on management of mass incidents with blast injury, yes, there is a section there on managing bloodborne virus risk, which is mainly vaccine orientated for hepatitis B. I wasn't particularly involved in it because it's not my area of expertise, but I think very sensibly in the conversations I was involved in amounted to, actually, you need a very detailed risk assessment from those on the ground who have an understanding of the nuanced epidemiology in that geographical area, and a decision will be made, and you will be told what to do in very short order for a mass event. I think if you've got something that you think presents a real risk, then I would deal with it the same way we would an inoculation injury. You know, you will have a GU service with recourse to advice there, and it will be done on a case-by-case basis. But I don't think you could make a sensible case for routine post-exposure prophylaxis with HIV antivirals, if that's what you were thinking about.
And the last question from Michael is more of a general question. Have you noticed an increase in antibiotic resistance?
Yes. Specifically in the instance of trauma, possibly not, but certainly in our institution, I'm ashamed to say that yes, we've got some carbapenemase producing Enterobacteriaceae knocking around. They knock around our ITU, as do our trauma patients. So where we see antimicrobial resistance, a lot of it is actually nosocomial infection. We had a pretty torrid time during COVID, as I know a lot of units did, and intensive care units, that they were under extraordinary pressure. They had a lot of practitioners who didn't normally work in that environment. And a bit of the human factors crept in. I am so worried about, I don't mean this disparagingly because I know the guys had a really tough time. I am protected from COVID. I've got all this PPE on, so I'm safe. So it's okay to go from bed space to bed space without changing gloves, without doing all the stuff that we normally do. They were time pressured, patients were crammed in. So we did do an awful lot of sharing of beasties there. And I think we're still seeing the tail end of that in many of our institutions. So yes, I do think we're seeing more, but I don't, for me, think it's particularly in the context of the trauma patients. And I don't believe it is driven by inappropriate use or overuse of broad spectrum agents in our trauma services. I think in recent years, they've been really good at buying into the message about being careful. And actually, I think we use a lot less antibiotics than we used to. And as I said, I don't think we're seeing a trail of devastation around that.
Debbie, thank you so much indeed for joining us tonight and for such a fascinating and engaging presentation.
Well, thank you very much for inviting me. It's been a real pleasure. And thank you guys for all the amazing stuff you do. My hat's off to you. I couldn't do your job. So thank you.
Fabulous. I will send you some of these really kind comments. There's some kind comments coming in now on the chat. So I'll post them to Dr. Debbie tomorrow. It's always good to get some feedback. So on behalf of myself and the trauma care team, if you are out there working tonight, please do stay safe and thank you for the amazing work that you are doing. If you are at home and you are on the settee, kick off your slippers, maybe pour yourself a glass of wine, maybe have a cup of tea, hot chocolate, whatever tickles your fancy, and enjoy the rest of the evening. But thank you so much for your continuing support through these challenging times. Take care, Dr. Debbie. Thank you so much indeed again.
Thank you. Bye-bye.
Take care. Bye-bye, everybody. Thank you.